Good afternoon, everybody. I hope you are enjoying your congress. It is a pleasure for me to speak to you today. Thank you very much to Dr. Jaime and the organizers for the invitation. And I'm very sorry I cannot be with you. I am speaking to you from SynLab head office in Germany. This afternoon, we are going to talk about pharmacogenetics, and very specifically about pharmacogenetics in psychiatry. But I could probably give a very similar talk in immunology, in gastroenterology, and in neurology. We take psychiatry as an important example. And the question we are asking is, has the time come today to start using pharmacogenetics to personalize therapy in psychiatry? So you all know that psychotropic drugs, antipsychotics, antidepressants are not universally effective. As you see here on the left, only about half of patients with major depressive disorder respond to their first-line treatment of antidepressants. And if we look more specifically at SSRIs, selective serotonin reuptake inhibitors, only about 1/3 of patients with MDD respond, and only about a quarter achieve remission of their disease. So that is a low efficacy of the drugs, but also the drugs have some sort of toxicity. About half of patients have at least one undesirable side effect, an adverse drug reaction due to their treatment. So we're confronted by giving the same treatment, we think we have a similar diagnosis, but in different people, the pharmacological approach does not work in the same way. It is inadequate. And as a result of this, patients typically in psychiatry undergo the trial and error approach we have used for so many years, adjusting the dosage, maybe switching medication until you find the right mix for your patient. And of course, patients who are undergoing this, they are not very motivated, they suffer from it, they display poor adherence, and may well discontinue their therapy. If we take a broader view, so outside of psychiatry, and we look at adverse drug reactions, there are many, many studies of adverse drug reactions, all of them a little bit inaccurate because healthcare systems are not good at recording adverse drug reactions. In the UK, 4 years ago, there was a systematic review and meta-analysis by NICE, which identified amongst primary care patients, about 8% had adverse drug reactions. If you move to inpatients in hospitals, between 10 and 20% of such patients are thought to have adverse drug reactions of some sort. And in one study, over 2% of people who were admitted because of an adverse drug reaction died in hospital. In Sweden, this is the highest frequency or prevalence I found in any study. In the 6-year period from 2013 to 2018, the Swedish study suggested a prevalence of adverse drug reactions of 10% in the entire population. And furthermore, one systematic review found that almost 4%, between 1 and 15% of hospital admissions were drug-related and preventable. And remember the figure above, that over 2% of these people may die after admission because of their adverse drug reaction. These are related. Not only is it a personal problem, a healthcare problem, but the whole healthcare system is negatively affected by adverse drug reactions. Again, there are not many very comprehensive studies, but these were two of the best in 2008. In the US, it was estimated that the total cost of adverse drug reactions was comparable to the cost of diabetes. A few years later, in 2019, the cost of diabetes was over 200 billion US dollars. At the time, they estimated over 100,000 deaths per year were caused by adverse drug reactions in the US, which made it the fourth leading cause of death by disease. If we move to the EU, a similar sized population, a study at the same period suggested that up to 5% of all hospital admissions are due to adverse drug reactions, similar to what we saw on the previous slide. And approximately 200,000 deaths per year in the EU were thought to be perhaps caused by ADRs. And it was estimated to be the fifth leading cause of hospital death. At the time, the estimated cost, in 2008, it will have increased since, to society was believed to be about $80 billion. So these two sets of data, US and EU, are largely comparable, which gives some confidence in their findings. Now, we have drugs that are not always efficacious, they don't always work. We have drugs that commonly give secondary effects of toxicity, but this varies between individuals. And there are a huge body of data now showing that a large part of this variation between individuals is down to genetic variants. Otherwise, I would not be talking about pharmacogenetics today. In 2013, one such study suggested that 42% of the individual variation in antidepressant response was down to common genetic variants, excluding the rare one. And this leads to the idea, can we use studies in pharmacogenetics to avoid serious adverse drug reactions? Can we replace the standard trial and error approach with early testing, early personalization of the therapy to get the best chance arriving at the right drug at the right dose from the start? And can this provide a tool that will optimize your clinician's choice of the best drug for your patient? And the side effect of this, if it's effective, of course, would be to decrease overall health costs because of the reduced ADR, reduced hospitalization and morbidity, and more efficient prescribing. Our pharmacogenetics, I'm going to explain some of the principles behind it, but don't worry, we're not going back to med school. If you take out oncology, which I will not be talking about in detail today, the treatment of actual solid tumor, pharmacogenetics is basically the genetics of ADMET. So the absorption of a drug into the system, how it is distributed around the body, how it is metabolized, most commonly by the liver, how it is excreted, either in the bile or in the kidneys, and what is the toxicity of this drug. All drugs essentially are toxic if they're any good, but we want to control the toxicity and control the ratio between positive effect and negative effect. Now, the genetic variants in all the genes involved in this ADMET cycle allow you to predict the effective dosage of a drug. Not what I'm giving, how much my patient weighs, but what will get into their system, how can I get them into the therapeutic range? And you know this basic principle, this is how pharmaceutical companies work. When they study a new drug, they determine the dose that is necessary, they determine the frequency of taking the dose, maybe with a body mass adjustment, to keep the patient as much as possible in this blue zone in the therapeutic range. Now, if you have a genetic variant that decreases the effect of one of the enzymes or transporters in your ADMET proteins, one effect might be, if you do not degrade the drug you're being given like other patients, you slowly increase the amount of drug in your circulation. And so initially you're in the therapeutic range, But because you're not excreting the drug as expecting, even if you're not excreting, you're not metabolizing it, you will move slowly into overdose, and you will start showing more severe adverse drug effects. In a similar way, you may have a genetic variant that increases the activity of an enzyme and means that you very quickly break down the drug you're being given. And even though you're taking the correct dose for the general population, for your individual patient, you cannot keep him in the therapeutic range. These graphs are taken from the example of paroxetine, which is broken down by CYP2D6, which we will come back to, a liver enzyme that breaks it down, inactivates it, prepares it for excretion. This is the basic principle. We want to identify people with these genetic variants so that we can keep them in their therapeutic range. Now, a few more statistics, this time not about the general population, this time about the drugs and the genes. Approximately 90% of prescribed drugs in the Western world are metabolized by the 6 genes listed here. It may be an important effect, it may not be an important effect. We know that drugs have different therapeutic ranges. Some are very dose sensitive, some are not. But about 90% of drugs are metabolized just by these 6 genes. And if we take the whole panel of ADMET pharmacogenes, almost everybody carries at least one significant genetic variation affecting the activity of one of these genes. And basically, everybody has at least one. Many people, we will see a case later, have more than one genetic variant in different genes involved in drug metabolism. And at the latest count, and this was earlier this year, I last did the count, in the FDA, about 300 drugs, a little over 300 drugs, took into account pharmacogenetic data on their package inserts. Some say testing obligatory before giving, some say testing useful, some say testing should be taken into account if it's being done. Now, this was studied in a lot of detail by the group of Mehta in 2020. And at the time, they took all the drugs in the FDA register for which there was a gene drug pair listing. You're going to give your patient drug A, look at the drug label. Ah, yes, it says that this is affected by a certain gene. This is a gene drug pair. Now, on the left-hand side, you hear under oncology, the great majority of such drug gene pairs are in oncology, because these are targeted at specific tumors. You've heard about this in liquid biopsy and solid tumor testing. This is not the subject of this talk. Here we are talking about not somatic disease, but a constitutional situation. And you see that the top 2 group of diseases with drug gene pairs, according to the FDA, are psychiatry and infectious disease, closely followed by neurology. This is one of the reasons we picked psychiatry for today. There is a lot of pharmacogenetics in psychiatry. They also looked at this in another direction, and it was no accident that I gave you the first example of CYP2D6, everybody's favorite pharmacogene, because about half of drug gene pairs associated with CYP2D6 are in psychiatry. You see the big orange box here, and almost the only orange across the whole field, so psychiatry, is under CYP2D6. A little bit in CYP2C19, a little bit elsewhere, but you see the outlier here is CYP2D6 and psychiatry. So we will address it further. Now, I'm obviously trying to convince you that it's useful to do a genetic test to help your prescription in psychiatry. How do we get from genetic test, the lab tells me this patient has an A instead of a T in his DNA, supporting my prescription of a patient with psychosis or with depression. There are a number of professional bodies who compile data from the scientific literature. So this is very much a combination of medical scientific research reaching a sufficient level of evidence to feed into recommendations. And I wanted to give you this slide to give you the key names. The most important name, one thing to take home with you today, is clínica, which is an outstanding publicly available website with a huge compilation of pharmacogenetic data. You can look up a gene, you can look up a drug, and you will learn about the recommendations in different countries in the world. If you're interested, you can learn about the biology. It's a really outstanding medical resource today. And through these resources, we can go from my patient had an A, not a T in his DNA, to saying how you could use this in prescription. And I will walk you through this process now. So initially, I must say, I've already excluded oncology, tumor-specific pharmacogenetics. Constitutionally, there are two approaches to pharmacogenetic testing. They are very, very different. On the left, we have what can be called companion diagnostics. This is the gene-drug pairs with the highest level of evidence. I give you a list of what is recognized, at least in Europe, as the most important gene-drug pairs. In all these cases, it is strongly recommended professionally to test the gene before prescribing the drug. So if you're going to prescribe 5-FU in oncology, you should be testing DPYD activity before doing so. Before giving clopidogrel to a stroke patient, you should test CYP2C19 and so on. These companion diagnostic strong gene-drug pairs are almost always linked to a risk of severe morbidity or even mortality when prescribing the drug. And based on the results, there are guidelines saying reduce the dose, change the monitoring, look for an alternative treatment. Again, today I'm not talking about these companion diagnostics. We are talking about the right-hand side, preemptive, specialty-specific panels, multi-gene panels. The level of evidence is a little bit lower than companion diagnostics, but I'm convinced today that this is really moving into clinical utility. So a PGX screening test, you may want to offer it to your husband for his 50th birthday, or you may want to use it in your practice. You're having trouble treating a patient with depression. You cannot find the right treatment. Maybe a PGX screening test is what I need. No two laboratories have the same test, I'm afraid. I hope all laboratories give equally useful and understandable information, but there is no standard test. The common tests today analyze typically between 25 and 35 genes. These are the ones where there is good evidence for utility and a good way of using the data to adjust your prescription. And they will typically analyze 150 to 250 genetic variants. As genetic testing gets cheaper and as the analysis, the data is better, these numbers increase. And these genes are typically in phase 1, drug metabolism, in phase 2, drug conjugation, preparing it for excretion, phase 3, drug transport into cells or then in excretion. And behind each little square here you see is a drug. We are concentrating mostly today on our favorite gene, CYP2D6. Behind each of these genes, there are tables based on the literature, such as this, where you have the genetic result. This is an interpretation A, T, C, G, at particular places in the gene. We classify the genes as alleles, the normal, most common allele for most genes called star 1. You see for CYP2D6, there's a whole run of genetically different versions of CYP2D6, but we consider these all as normal and we categorize them as having an activity of 1, normalized to 1. Some genetic variants listed here, and there are many more but very rare ones, have a reduced function that we classify as a 0.5 activity, reduced function allele. And many genetic variants, most common, reduce the activity of the enzyme to almost nothing, activity value 0. We consider these as non-functional alleles. And in some genes, you can have an increased activity. For example, in CYP2D6, you can have multiple copies of a gene. And this will, of course, increase your activity, but the exact change in activity, you need to look in detail at the laboratory's report. If they say there is a duplication, you have to say, what does this mean for the activity of the drug? The laboratory is unlikely to give you these tables. They should give you something later in the pathway we're looking at. And then each person, of course, has 2 alleles, what we call the diplotype. If you have 2 normal alleles, your activity score would be 2. If you have 2 reduced activity alleles, your activity might be 1. If you have a duplication of a normal allele, you may have an activity of higher than normal of 2.5. And then these activity scores are taken by the laboratory to generate what is more useful to you. My score for CYP2D6 is 0. I am a poor metabolizer. It is between 1 and 2. I'm a normal metabolizer. It is above 2. I'm an ultra-rapid metabolizer. And these phenotypes, predictive phenotypes, are what you use to refer to the literature. What is the situation for a particular drug? So you will receive your PGX, your pharmacogenetic report from the laboratory. You'll have a list of genes. They will probably list the diplotype. This patient has the CYP2D6, has the allele star 4, star 5. And we give him an activity score 0. So you know this patient is a poor metabolizer CYP2D6, at poor activity in this other gene DCHE, and so on. You'll get a list like this. But this again doesn't tell you which antidepressant can I use in my patient. And we need to convert into individual drugs. To do this, there's another twist in our tail, because enzymes such as CYP2D6 can activate some drugs, but they inactivate other drugs. One of our standard drugs for teaching this principle is codeine, and you know, a moderate strength analgesic. Codeine on its own has basically no analgesic power, but it is converted in the liver by CYP2D6. It is activated and converted directly into morphine. And of course, it's morphine in the body that has the analgesic effect and also the side effects. So in the previous example, we had a CYP2D6 poor metabolizer, like about 10% of the Western population. The guidelines say that this patient may experience reduced or no analgesia from codeine. I tell you a secret, the report we just saw was my own, and I can tell you codeine has 0 effect. If I go to a codeine party, I am the last man standing. Some people, about 1 in 50, it varies between ethnic groups, are what we call ultra-rapid metabolizers. They have an activity score above 2, and the therapeutic recommendations here are very strong. Everywhere with pharmacogenetic recommendations, these are really strong recommendations. There is a higher adverse reaction risk, which can be life-threatening. It can cause respiratory depression and death, particularly in children, because of such accidents that codeine is not used in young children. And the indication is to change the drug. You do not give codeine to these patients. You switch to an analgesic, which is not activated by CYP2D6. So that's activation of the prodrug to a drug. But we can go the other way around as well. So back to psychiatry. We take the example of amitriptyline. Amitriptyline is the active drug. You give your patient a pill containing the active drug. And it is inactivated in the liver by CYP2D6, and it becomes a compound which has no antidepressant activity, but some of the metabolites are actually cardiotoxic, which gives us another problem. So again, let's consider that you want to put me on amitriptyline. I am a slow metabolizer for CYP2D6. The risk of side effects is increased because I maintain a too high level of amitriptyline as if I'm in overdose. So the amitriptyline side effects I am more likely to have. I will probably have lesser risk of the cardiotoxic metabolites. But the recommendation is to consider an alternative drug or to use a reduced dose. And if you use the reduced dose, you should monitor the effect and the side effects or the plasma concentration. The ultra-rapid metabolizers will very quickly degrade amitriptyline, and so it's likely we will not get the positive benefit of treating our patient, but we are going to quickly produce the cardiotoxic metabolites, and so there is a risk of generating cardiotoxicity. So the guidelines, they're a little contradictory. They say you should increase the standard dose, you should give more drug to get a positive effect, but also you must monitor the metabolites, because if you reach a cardiotoxic level, you have to avoid amitriptyline and switch to another drug. And so now we have enough tools to be able to say, I've done my genetic test and I can predict in my patient what is happening when I give him a particular drug. And your laboratory report, wherever you get it from, will give a similar table to this one. Go into the nervous system. We are in the antipsychotics, now down in the antidepressant. Here is amitriptyline. We know we have a CYP2D6 metabolizer. This is an alert level, a red D in our report. Exposure to amitriptyline into the risk of adverse effects may be increased. Use should be avoided. And then they talk about how to modify, how to follow up. Now, it's not all bad news. You may be thinking, oh no, I do the test and I won't be able to treat any patient with anything. But at the same time in these reports, you get positive outcomes. You could look a little further down. Well, maybe I'll try sertraline on this patient. That's my second favorite drug. If amitriptyline doesn't work. And you can see that this patient, me, I have no counterindication to using sertraline. According to my genetics, it should work as it's written on the label. And so I know to avoid amitriptyline, and I have an alternative treatment. So are we ready for personalized prescription? Are we asking you to be cowboys, pioneers, or are there reasons to do this? 6 years ago, back in 2019, the International Society of Psychiatric Genetics published updated recommendations. They're still current. I don't know if there's a new statement in preparation. Inside these recommendations, which were not just on pharmacogenetics, but across genetics in psychiatry, their recommendation number 8 said pharmacogenetic testing should be viewed as a decision support tool to assist in thoughtful implementation of good clinical care. I really like these words. It doesn't say you have to do the test and you have to obey the rules, what the test tells you. It says this test can help you in giving better care to your patient. So it's really to support you and not to tell you what to do. And similarly, if you look at the CPIC database, which is one of the major pharmacogenetic databases, and one of the major organizations producing guidelines about the use of pharmacogenetics, 6 genes listed here, 4 CYPs, and two HLA genes are assigned with a level for psychotherapeutic treatment which says that there is sufficient evidence supporting their clinical utility in psychiatry. Again, not you must do it, but if you do it, it can be useful to you. And this is why, in a way, it's different to companion diagnostics we saw earlier. Companion diagnostics you must do. If you don't do it, you are making a mistake. Pharmacogenetic screening, it will help you. It may well improve the way you prescribe, and particularly for some patients, it will help you find an effective treatment. Does it work? Again, we're still waiting for the really large study, but this was one I pulled out a couple of years ago, 2022, it was published. A small study with about 50 patients with bipolar depression, about 50 patients with major depressive disorder, split into two cohorts, one tested with pharmacogenetics before prescription, and one treatment as usual. And all four measures that they used, which to be honest, I'm not a psychiatrist, I couldn't explain to you in detail, all four measures showed a highly significant improvement in the pharmacogenetic guided group to the treatment as usual group. It's not a guarantee, it's not obligatory, it will not solve everything, but the evidence is very strong that it can and will improve the choice of treatment. Just a couple of cases to finish. The first, a very standard case. The second, an interesting case from a general practitioner I worked with in Switzerland a couple of years ago. So Pauline is 54 years old. Her husband died recently, and she's depressed. Her GP has been treating her for a few months with sertraline, but she suffers from insomnia, headaches, she has dry mouth, she has nausea, she has diarrhea, and the GP wonders, is this part of her condition or is this directly linked to my sertraline treatment? And he says, can you tell me if sertraline is the right drug? And I wonder about switching her to paroxetine. Sertraline and citalopram is a very similar story. They are selective serotonin reuptake inhibitors, as you know, commonly used antidepressants. Both are degraded by CYP2C19. We won't look in detail, but you see that the major pathways degrading sertraline are CYP2C19 based. And CYP2C19 is perhaps the second most important pharmacogene in psychiatry. After CYP2D6, you should really be considering CYP2C19. Additionally, it's much easier to test than CYP2D6. CYP2D6 is complex, a little bit expensive. CYP2C19 is very easy to test. A lot of genetic variants, and about 1 in 4 people are poor to intermediate metabolizers, and about 1 in 3 are ultra-rapid. So the population splits in 3 groups: poor, normal, ultra-rapid. We tested Pauline, and here are test results, CYP2C19. We have a diplotype result. We do the analysis, and we say she is an intermediate metabolizer, like about a quarter of the population. And we noted also that she is a CYP2D6 poor metabolizer, 0 activity. So what can we tell our GP who wants to understand the treatment? One other point, a very important point, sertraline, just to complicate our life, inhibits CYP2C19. CYP2C19 inactivates it, but it also inhibits the enzyme. And so Pauline, who is an intermediate metabolizer, taking sertraline, the little bit of activity she has left may be inhibited, and she may become a poor metabolizer, even worse probably. If we look at the guidelines, published guidelines, dose reductions of 60% in poor metabolizers and 25% in intermediate metabolizers for sertraline should be used to avoid the risk of overexposure. So we have an answer. We are giving her too much sertraline. We should reduce it. but maybe we could change it to paroxetine. Unfortunately, paroxetine is metabolized by CYP2D6. Pauline has no CYP2D6 activity. And so if we want to switch, we should start her on a 50% dose and titrate until we get a good response. And so we've learned probably why she is having side effects, and we have two possible solutions. Neither of them perfect. Maybe we'll have to look for a third antidepressant not metabolized by CYP2C19 or CYP2D6. And our second and last case, this is, as I said, a case submitted to me by a GP in Switzerland, which he presented at the European Society of Human Genetics. Natasha was about 70 years old. She had suffered from anxiety, depression. She had sleep disorder. She said for years, I cannot tolerate them. I can't take any meds. And recently, she's really not been feeling well. Her blood pressure and pulse rate are all over the place, but the cardiologist finds nothing wrong with her. We put her onto bisoprolol, and she developed a sudden bradycardia. We dropped the dose, still bradycardia. Without bisoprolol, she had a borderline tachycardia. She said, I'm not surprised. All my life it's been like that. We did a pharmacogenetic test on her, slightly different looking report. As I said, no two labs did exactly the same test. We saw she was a CYP2D6 poor metabolizer, one other CYP, a few transporter genes. She had low function, and one conjugating enzyme. She was also a poor metabolizer. So CYP2D6 immediately gets our attention. All the others, we're not quite sure what they do, but they all have effects on different genes. And we combined this with a treatment and found that because of the genes you just saw, for bisoprolol, she had a risk of increased side effects, and the side effects could be either tachy or bradycardia. For zolpidem, she was given for her sleep disorders. She'd had a nocturnal fall. There was a risk of increased toxicity. For her depression, she was given mirtazapine at the time, which noted a risk of increased toxicity. And the atorvastatin she was on also showed a risk of increased toxicity, an increased risk of myalgia. Based on this, the GP decided to come to polypharmacy. I can't change one at a time. I'm not quite sure where I am. And for all of these drugs, he found alternatives. He swapped in for drugs which had no pharmacogenetic contradiction. As I said, the evidence wasn't ultra strong, but there was good evidence in the literature. And for each of the three drugs he switched her to, he had no contraindication pharmacogenetically. He stopped the atorvastatin while he was trying to stabilize the rest. And for up to a year after this change, she was much, much better. The sleep disorder disappeared. The anxiety was better controlled, and she had much less tachy or bradycardia. So PGX helps also in polypharmacy. So basically, the panel approach, in a way a summary before a last little story, can support you finding the right drug at the right dose from the start. It can explain to you why the drug is not working on this patient or why I have more side effects than I would expect. And it can also, perhaps most importantly, help you find alternative medications that you can pick according to your judgment. But genetics and pharmacogenetics is always full of surprises. Last little story. We did a pharmacogenetic test for a psychiatrist in the Italian part of Switzerland, in Ticino. And the patient report came back. You don't need to read any of this. You just need to see that every single drug, every single gene came back labeled green. This patient was pharmacogenetically perfect. And I thought, wow, that's really weird. And my first reaction was to speak to the bioinformatician. Something has gone wrong. He said, no. I've run it again. This patient just has completely normal farmacogenetics. So I spoke to the psychiatrist. I think, oh, she's going to think the test is useless. This is not good business for a laboratory. She will never ask for the test again. And she sent this back. I give the exact text that I'll translate it. She said, oh, we weren't at all surprised. I'm not at all surprised at this result. And it was really useful for the therapy of this patient because now she can no longer invent abnormal drug reactions, adverse drug reactions for every single treatment I get her. And I hope she will be much more compliant. Thank you very much. And so with that, thank you very much for your attention, and I wish you a good end this afternoon to your conference.